stuff about hepatitis and kind of cirrhosis at the same time. One thing that we didn't, there's different kinds of cirrhosis. There's alcohol cirrhosis, there's non-fatty liver disease, there's Wilson's disease. Don't do that to yourself. But I've talked about portal hypertension, esophageal varices, coagulation. I'm sorry, I flipped way forward. What we haven't talked about here is cirrhosis. Ascites related to cirrhosis. So people that have chronic liver disease, cirrhosis of the liver, will often get ascites. What's ascites? The fluid buildup in your abdomen, okay? Think about that. One of the things that your liver does is protein. If I don't have enough protein, where's my fluid going to go? If I don't have enough protein in my blood, where is that fluid going to go? Yeah, it's going to bleed out into my interstitial spaces, and so then I get this big fluid in my abdomen. That ascites, that fluid backup. And it can be, people can hold a lot of fluid. Just keep reminding me. I take it down, I don't even know it's down. I thought it was funny that Michelle said to you guys in class that you don't have to wear a mask, and somebody in here said, oh, we're still going to have to wear it in my class. I'm the worst one of all of us about keeping it on my face. Like, of course you're not going to. Has anybody ever gotten to see a patient with ascites? Yeah. It's a lot. It can be a lot of fluid, and they can tap that belly. What's the procedure we talked about at way at the beginning? Paracentesis, where you're going to drain that fluid from somebody's abdomen, and it can be liters. I mean, they can take liters off. Did somebody tell me a story after that about how many liters?
The Statner cycle says that he saw you get 8 liters.
8 liters. Okay. So here's what I want you guys to think about. They can do this at the bedside. They can take it down to CT and do an ultrasound-guided paracentesis. They can do all kinds of different things, because when they do that, they don't want to poke an internal organ when they do it. So sometimes, when it's really bad, they'll take it down and do it under CT. I think if I was going to have somebody do that, I'd want it done under CT. Don't poke the internal organ, but especially because I'm a bleeding risk. If you're removing that type of fluid, you can cause people to have problems with fluid balance, because they're normally now used to carrying around this extra fluid. Even though it's in an interstitial space, it's extra fluid. And so you rapidly take that off like that, you can really cause somebody problems. So if I have a patient that's in CT, or the physician comes and says, sorry, Ashton, you caught my eye. Ashton, I want to do a paracentesis at the bedside. What kind of things would I want to have at the bedside for my patient? What? Oxygen, yeah, maybe.
Didn't you get rid of electrolytes and stuff?
You might want to put them on the monitor, but absolutely have a blood pressure cuff on them, some way to check their heart rate. Because if I'm pulling all of that fluid off rapidly, what would that do to their blood pressure and their heart rate? Yeah, they normally will have high blood pressure because they have portal hypertension, they have high blood pressure, they have it back up in their lung or in their portal vein. But if I'm rapidly removing that, I can have a shift, and I need to be careful, and I need to look at like repeat lab work and things like that after the fact to make sure that I don't have the next day electrolyte imbalances.
Is there a way, like, so obviously everybody holds a little bit of different levels, like amounts of fluid. Is there like a way to know how much you should be taking off of a person, or like?
That would be a physician decision. That would never be a nurse's decision as to how much fluid to remove. It would be the physician deciding how much to remove safely. Yes. I would never want to make that decision. That's why they went to school for 18 years and get paid a lot more money than you and I do. They're at risk for infection, and they're at risk for bleeding after those procedures. Remember, you aren't doing clotting factors. You've got all of this fluid in here, and it can be anything from clear, yellow, like serosanguinous, gunky, like they can get stuck in growth. You have, like, you're shaking your head like
I've
you've
seen
seen
some that look almost like skim milk coming out.
skim milk or like coffee with a lot of creamer, like that. Sorry. It looks like what Alyssa has in her drink. Hold that up. That's, I've seen it look like that. Finish that off. It's okay. You'll learn. You'll have a stomach of steel. It's okay. So cirrhosis, edema. What somebody on break asked me about the heart. If I have a backup of fluid in my vascular system, it will continue to back up. And I'm going to end up affecting my heart because I'm holding on more fluid than I should. We'll get into heart here pretty quickly, but you talked about it in patho. If somebody has right-sided heart failure, that's where fluid is backing up. It's in the abdomen, they get the dependent, it's that systemic edema. Versus left-sided where it's backing up into the lungs, okay? Here's a little clue. People that have right-sided heart failure develop left-sided heart failure, and people that have left-sided develop, because it's a closed system, and so it's gonna back up, it's gonna damage the other. And this is all part of that circulation loop. Your liver is part of that circulation loop. And so if you have liver damage, it's going to eventually affect your heart, and they will have heart damage. And that's, you're gonna get edema, you're gonna get all kinds of fun things, you're gonna get clotting factors, you're gonna get thrombocyte, what's thrombocytopenia? Low platelets, you betcha. Which would be less than what? Would be less than what? Less than 100,000, right? Would be thrombocytopenia. I talked about antiviral agents, treat hepatic disorders, diuretics. What are your diuretics? Spironolactone, hydrochlorothiazide is a good one because it's a combination diuretic blood pressure medication. The thiazide is the diuretic. Spironolactone, however you want to call it. Furosemide is Lasix. Bumex is another one that you can use. So diuretics help get rid of fluid. Help get rid of fluid, not necessarily ascites, but the fluid that's backing up in that vascular system. Does that make sense to everybody? If somebody has ascites and I go in and hit them with a big dose of Lasix, that's not going to get rid of the fluid that's in their abdomen. Lasix is going to get rid of fluid that's in their vascular system. People that have a dependent edema, we get rid of that with Lasix because once I decrease the vascular congestion, then what's pushed out in those interstitial fluid will come back into my vascular system. Hyperosmotic laxatives, which is your lactulose, I talked about that. So you're giving them you give it orally, and you can do enemas, I guess, but usually we give it orally. And it's hyperosmotic, so it pulls fluid in, and then it has a medication that binds with ammonia, and then they poop it out, like massive amounts of poop. Super good. Neomycin will reduce it in the blood. Neomycin is an aminoglycoside antibiotic. If you remember back to farm, aminoglycosides, neomycin is a big one, and it reduces blood ammonia. Synthetic hormones, another thing that your liver does is it helps with hormone regulation. We didn't talk about that. So men that have cirrhosis or hepatitis will do things like grow breasts. Gynecomastia is breast growth in men. Women will have irregular menstrual cycles. They'll get irregular hair growth. So things that you don't want to have happen can happen. And so synthetic hormones sometimes, immunosuppressant medications, these are your interferons that I talked about earlier. Paracentesis. So monitor the heart rate. Gosh, I didn't even remember that was on the slide. I just remembered it. Anybody in here have their gallbladder removed? Have you had your gallbladder removed? How did you know you had gallbladder issues?
Oh, anytime I could eat anything that was greasy,
terminology, and this, there's like, please, there's like no, you're not gonna find this in the textbook. Fair, fat, 40, and female. Those are your high risk.
See, classic.
No, I'm like, after you said that, I'm like, oh, now I'm gonna say this, and you're like, thanks, you're not fair. You're not fair. So the lighter skin, overweight, over 40, your combo, and over 40, yeah, are risk factors for gallbladder disease. And typically when people get a gallbladder attack, it's after they eat a really high fatty or greasy meal, and like 30 minutes later, they're having acute pain in that right upper quadrant. And a lot of times they'll complain of pain in their back or in their right shoulder blade, too. That referred pain. So it is not comfortable. Nausea and vomiting, intolerance to fatty food, gas, bloating, abdominal distension, diarrhea. Remember that bile helps break down fat, so they'll get fat when they do have stool. It's that fatty, that's steroidea stool that kind of floats on the top of the toilet and is greasy. Light-colored stool sometimes. I'm sorry, it's the poop module, Jaden. I don't know what else to do. Light-colored stool, because you don't break down the fat and save a lot of fat in your stool. Chest pain. Women will come in and they'll say, I have chest pain, but it's not chest pain. It's just because it's so painful here that they think it's in their chest. And then fever and chills because of the infectious process that's going on. It's inflammation of that. Most commonly, it's caused by gallstones. It's blocking that common bile duct. So it's there's stones in your gallbladder, and it's obstructing here so the bile can't get out of the gallbladder into the ileum, that intestinal tract, to break down that fat. So it stays in your ileum, well, that fat stays in your ileum and then goes through the rest of your digestive tract and doesn't break down. Okay? So they can remove your gallbladder. And did they tell you have to watch what you eat, or can you now just eat whatever you want? You don't really have a problem.
I pretty much
Which I think is bizarre because you don't have that organ that would help break down fat, but all of a sudden now you get that gallbladder removed and people seem to be able to tolerate diet okay after that. So it's an organ like the appendix that you can live without. Gallstones are gross. They can be made of all kinds of things. They get caught in there. They calcify. They're gross. Just like your appendix, your gangrene can get swollen, or your gallbladder can get swollen and perforate. It can rupture. It can get gangrenous. What does gangrenous mean? Dead tissue. Gangrene is death. Necrosis, tissue necrosis. If I get tissue necrosis, I'm in my body and in an organ. What am I at risk for? I have dead tissue in my body. Septic. Yeah, I'm very. Yeah, absolutely. Yes. Yes. If that infected organ gets gangrenous and ruptures, yeah, you're going to get peritonitis, just like you do with any other organ in that area that ruptures. Cholecystectomy is the surgery, and they can usually do that laparoscopically. They puncture, take a couple holes, scope, go in, get it out. Did you have yours done laparoscopically? Occasionally, if it's really, really bad, they may have to open them. I've seen where they've gone in laparoscopically to pull it out, and it is so friable, it just like disintegrates as they try to pull it out. And so then they have to give them post-operative antibiotics because now they've had that happen inside them. They can do a T-tube. So here's your common bile duct. So this little bile duct that's right here, sorry. You can have a tube that they can slip in there. This is the outside of your body. The tube goes into this common bile duct to try to keep that open and let the stones pass. And so then they leave it in there for a while, hopefully your stones pass, and then they can pull it out. The biggest complication of a T-tube is bile is very harmful to the tissue, your outside tissue. It can cause lots of skin breakdown. And so, because they have this tube in here, bile can sometimes break and come out this way too, and irritate the skin. So if you have somebody that has a T-tube, watch for the skin around that tube to make sure that it is not causing skin breakdown. Good care of that skin around that tube. They might be NPO with a possible NG for a while. Same rule of somebody that has pancreatitis or, not pancreatitis, appendicitis. If they come in and it's an acute infection, they may give them a few doses of antibiotics and let it cool down before they take them to surgery. If they think it's going to rupture, they're going to take them, okay? They can also do this ESWL, ultrasound shock wave lithotripsy, where they're going to go in under ultrasound and try to bust up those stones. And hopefully you'll pass them. So here's your fair fat female over 40 is what is the most risk. Pancreatitis is usually caused by alcoholism. That's the most common reason that people end up with pancreatitis. Most people that have pancreatitis will have multiple bouts of pancreatitis. They'll have it and then they'll get it again and get it again until it's like chronic. Can become chronic. There are other things that can cause pancreatitis. An infectious process can itself cause pancreatitis. So don't just assume that everybody that's admitted with pancreatitis is an alcoholic. And I say that because that's a very common assumption in the healthcare field. And Abby, George, you're like nodding your head off your body as I'm talking about this. Everybody comes in with pancreatitis or cirrhosis and we assume that they're an alcoholic. And that's not necessarily the case. It is the #1 cause of it, but not everybody. Big things about pancreatitis. If you have somebody that comes in with pancreatitis, it is incredibly painful. It hurts. Abdominal pain. They will be NPO until that inflammation subsides, and it may require them to have a G-tube or an NG tube to suck that out. If you have somebody that has pancreatitis that lasts for several days, they may start them on TPN because we can't feed them. Pain management, so opioids. We're going to give them that pain medication IV because they're not taking anything by their mouth. H2 receptors or PPIs. If I have somebody that can't take anything in their mouth, I'm probably giving Protonix IV. That's my PPI, right? Famotidine, you can give Pepcid IV push too. Until I get over that. What's your pancreatic enzymes? 2 of them. Amylase and lipase. You bet. Know what an elevated amylase and lipase look like. Be able to tell me that. The other big thing about pancreatitis, what is one function of your pancreas? What is it? Somebody's saying it. What are you saying? Somebody's saying it over in this area. What is your insulin? Insulin production. So people that have pancreatitis will have elevated blood glucose. They won't produce insulin, they won't break it down, and you will be doing blood sugar checks on them. And they will ask you, why? I'm not diabetic. But at this time, they're not producing insulin, and so you're going to need to artificially give them insulin. And it's not oral blood glucose medications. You will be giving them insulin injections. So make sure that you do good teaching and education, because once the pancreatitis subsides, then they can come off the insulin. But they may have to go home for a period of time on insulin Make sure that you're teaching them how to check their blood glucose and administer insulin, because if they go home, they just keep administering insulin and don't check their blood glucose, they can kill themselves. So they need to make sure that they know what that blood glucose level is. Low-fat diets, low-protein diets during acute infectious process for pancreatitis. Those are like the big things with pancreatitis. Let me hit obesity real fast. You guys know about obesity, right? Number one health concern in the United States is obesity. We have a hugely obese population. Know how to calculate BMI. This is not new. Know how to calculate BMI. You will have a math question on the test that requires you to calculate BMI. I'm telling you that right now. Waist circumference greater than 35 inches in women and 40 inches in female or males is indicative of an elevated body mass index. Long-term obesity leads to overall health concerns. Obesity damages everything, just like diabetes. Obesity itself is a precursor to diabetes, heart disease, high blood pressure, hyperlipidemia, all of those fantastic things that you don't want to get, because all of those things lead to damage to other organs like kidneys, heart, lungs. Decreased life expectancy. It's harder to care for people that are obese. They have to stay in the hospital longer. It increases healthcare costs. So there's lots of things about obesity for the individual and then as the healthcare system as a whole. Has anybody taken care of a bariatric patient? Okay, there's special equipment sometimes that we have to get. The normal blood pressure cuff isn't going to fit your bariatric patient, so you need special equipment to care for them. Special beds, lifts, things like that to help them. What are they at risk for? Skin breakdown, for sure, because you can't turn them. They can't mobilize like a normal patient would. A lot of times they're on multiple medications, so they're at risk for polypharmacy and medication interaction problems. So cardiovascular disease, GI problems, liver problems, diabetes, musculoskeletal problems. Our joints were not meant to withstand that kind of strain over time. They're at increased risk for cancer. Metabolic syndrome. Do you guys remember metabolic syndrome? Once somebody gets into metabolic syndrome, it is incredibly hard to get them out of this. Okay? So metabolic syndrome is diagnosed if they have 3 or more of these things. So not all of them. So if they're on a medication for their cholesterol, it's going to hit both of these. And then blood pressure medication, they've got it. They're diagnosed with it. All right? Not just that they have it, but if they're having medication to treat it, that means they have it. Right? You don't take high blood pressure medication if your blood pressure is not high. So you may take the blood pressure and it may be within normal limits, but they're taking blood pressure medication to get there, so they still qualify. Does that, when I say that, does that make sense to everybody? Waist circumference, just know that this is in centimeters, but it's 35 and 40 inches. So it's the same thing, once in centimeters, once in inches. Don't let that throw you. Or glucose management, or diabetic. Diagnosis, weights, just the weight in and of itself, body mass index, fasting blood glucose levels, hemoglobin A1C. Do I have hemoglobin A1C on there? Surely I do, right?
Hemoglobin
What is elevated hemoglobin A1C? What would that be? Greater than 7. 6, 7. Usually once you have this, they want you to be less than 7. They really don't want you to be 7. Lipid profile, elevated lipid, elevated TS, their thyroid stimulating hormone, are all things that can happen. And then evaluating patients' comorbidities. Okay, what else is occurring? Do they have high blood pressure? Do they have heart disease? Do they have diabetes? Every time you add a comorbidity onto somebody, it increases their morbidity and mortality rates. With every comorbidity, morbidity and mortality increases. Okay? There's lots of different medications that you can put people on. And just hold on because they're on the next slide or another slide here. The best way to treat this is weight reduction. Okay? People can be on blood pressure medication, people can be on oral anti-diabetic medications, and if they lose a significant amount of weight, they will come off of that. Weight loss is the best treatment. It is hard to lose weight. I pray for all of you guys in this room that you never have to battle that. It's very difficult to lose weight. And most people cannot just wake up one day and say, I'm done, I'm going to lose weight. That may last for 2 or 3 days, maybe 2 weeks if you're lucky, and then you need some assistance. And when I'm not necessarily talking about medication, what do you think Weight Watchers is? Or it's not Weight Watchers anymore, it's or Jenny Craig, or you have all of these, oh my gosh, they're all over the place. And they come up, Noom is the new one, and all of this other stuff that you can do. Because it hits all of these categories. So it's diet, it's learning to eat healthy, it's learning to journal or keep track of what goes in your mouth. I would challenge you guys over a week's period of time to keep track of everything you put in your mouth. You'd probably be surprised what you actually just unconsciously are put in your mouth and don't even realize that you're eating. Decreasing that BMI, reducing calorie intake by 500 to 1,000 calories a day. Okay? Physical activity, 30 minutes of exercise most, if not all, days of the week. Behavioral therapy. This is food logs, self-monitoring, support groups, cognitive restructuring. That is, Noom is the big one on psychology. I don't know much about it. I haven't looked into that a whole lot. But that's the one, it's a different way of thinking. It's about restructuring, cognitive restructuring. And then there's medications that are out there on the market. Oralast was really big for a while, but it makes you have like really bad diarrhea. Yeah, it gives you poops really bad. It's still on the market. You can still buy it over the counter. Belviq is another one. It's a selective serotonin. It suppresses appetite and creates a sense of satiety. So it does 2 things. It suppresses your appetite and it makes you feel full. It makes you feel like you're satisfied. Bupropion and naltrexone is a combination. It's an antidepressant and an opioid antagonist. So that it's a combination. You're doing a couple of different things. So there's lots of different medications that are on the market. And it used to be this Contrave is kind of a newer one that's on the market is interesting. I have actually, there are a couple, and both of them are physicians, and they're big in weight loss therapy. And I was talking to her, and she said that we used to treat people with Contrave, and we put people on it until they lost the weight, and then we take it off because we felt like then they should be on it. And she said now the thought process has changed. It's probably long term. They need to be on it because once they pulled the medication off, people just gained the weight right back. So just kind of as they learn more, then that's changing. Bariatric surgery. We're seeing this more and more and more. And it's becoming more and more acceptable. And the rule of thumb used to be BMI greater than 40 in men or 35 in females with significant comorbidities. And insurance companies wouldn't pay for it until you had lost 10% of the weight and had been on a weight loss program for 6 months, and you had to see a psychologist, and they had to approve it. I mean, all this stuff. And you're seeing a lot of that stuff get repealed. Because what they now have come out and said is, it is more of a risk to carry the weight around than it is to have the weight loss, what would happen. The benefits of the weight loss surgery outweigh the risks of doing the surgeries. And we have all kinds of different surgeries that are out there on the market, where it's not just a complete removal of the stomach, you can do things that can be reversible. So bariatric surgery is becoming much more acceptable practice, and we see it more and more and more. You can have a restrictive bariatric surgery, you can have malabsorption. The biggest problem following people that have bariatric surgery is they have to adjust their diet drastically, because what you're taking a stomach that is this big and shrinking it down to the size of a walnut, essentially, if that. And so they can't just eat everything that they want. And they have to be very strategic about what they eat, because if all they're eating is Snicker bars, they're not getting, well, that might be good, they're not getting the nutrients that they need. So it's lots of small meals, very specific about what they eat in order to get the nutrients that they need. And they'll say don't eat and drink at the same time. Like high calorie, high density, high protein foods, small bits at a time. They're at high risk for dumping syndrome. Remember we talked about dumping syndrome because they've taken away the stomach, and they don't have that. But they're at vitamin and mineral, risk for vitamin and mineral deficiencies, so a lot of times they're taking supplements. The next few slides, all this is, and I'm not going to put a picture up and ask you these, is just different types of gastric bypass that can occur. Big risk, pulmonary embolus, huge infection, anastomosis leak, dumping syndrome, because of the immobility that happens after bariatric surgery. Usually they're staying in the hospital for a couple of days and then going home. Here's a problem with imbalanced nutrition. I kind of mentioned that. Like that's a thing. Deficient fluid volumes, they're not getting it. Pain, impaired physical activity, anxiety. Another thing that happens is they lose the weight really fast and they have all the skin. And so some of them have to go back in and have then plastic surgery to remove skin, but those skin folds can get skin breakdown. So good care of the skin during this time. Here, nursing interventions. It makes sense. Why would you need appropriate size equipment? Why would you put SCDs on your patient? I mean, those make sense to you. So please don't, I know I'm going kind of quickly because I want to get you through, but I have about a minute. Assist with skincare, pain medications. Do not reposition the nasogastric tube. Why? Because they'll probably have an NG tube and then come out, and I talked about this. Why would you not want to reposition this? It's in a certain spot. Where is it at? If they've done the surgery, yeah, it's where the surgery occurred. The anastomose ends together, so you're looking for bleeding there. You're not doing it for gastric decompression. It's there to assess that site where the surgery happened, so that if they bleed, you're going to catch it really early on, and it's not going to just bleed internally for a long period of time. Okay. Okay. I will see you guys on Wednesday. We'll talk a lot about nutrition that day. And then I'll see you Friday. And you don't have to wear a mask next Wednesday. Yes, and I do agree with that.
So when you're off in, you'll turn right there, like,
Does that make sense?
office desk.
Perfect.
Right around the corner there.
I didn't figure you'd care, I just was gonna flop you around.
I just need to get that one.
Tonight or tomorrow.
Hey, where am I supposed to be next week?
The practice field?
So I just walk out by the trap?
Yeah, we'll be behind, but we can come up to you.
Oh, no, that's okay.